And on that note, we're going to quickly dive into our next speaker, who really doesn't need any introduction. But I will try to outline very, very briefly some outstanding points about Lieutenant Governor Bethany Hall Long. She was sworn in, everybody knows, last week as the Lieutenant Governor, along with our new Governor-elect Carney. And she is a nurse and has completed a PhD, as well as her nursing administration from George Mason University, and is a member of the UD faculty and has been for over 20 years. She has received teaching excellence awards and has always shown a lifelong interest in both healthcare as well as being an advocate, of what I would call a public servant. As a legislator, she's been in our state legislature since 2002 as both a representative and as a senator, and now she is the Lieutenant Governor. And so I just would like to welcome Lieutenant Governor Bethany Hall Long.
Apologize that I wasn't here to greet you. A lot of people say I'm like a lot of sunshine and caffeine, but I really am excited to be here today. And Nancy, you want me to use the mic? Thank you.
Of course I do.
Thank you, Nancy. Thank you so much. It's good to be here. At any rate, I know when the issue of the invite went out for the conference to Governor Carney, he was very excited. Many of you have had the opportunity to work with our former congressman, now our governor, and to him, as well as our former governor, because I see many individuals here who worked with Governor Markell, healthcare is that driving force. Probably 8 or 9 of you were with me when we signed the all-payers data set legislation last year, which is a huge, huge piece of legislation. I know you've already talked about that, and I want to give a big shout out, to Laura and Ms. Howard and Julian and others on the board, and certainly as I look to Dean Matt and other colleagues here. You get the fact that we need to do transformation, and that's why you're here today. But when Governor Markell at that time, passing the baton to Governor Carney and myself as Lieutenant Governor, issued the statement that day, the number one issue facing our state's budget and nationally is around health care. And so we're turning to you, the experts, my colleagues, my friends, to really help us continue on that path. You've been doing this for many years. I don't know is Mr. Townsend in here from the board for the Healthcare Commission? He has been in my ear for years about the value of the workforce and workforce training. And as you come today, as you're putting the pieces together, as I look at, Dr. Rattay and certainly colleagues of mine, and as I mentioned, Dean Matt from the university, we've always been trying to look at the end point. And I think in healthcare, there really is never a certain end point, but we're really trying to get to those 3 tangibles, right? Access, cost, and quality. And as you saw this morning by some of my colleagues in health theater, who we use all the time and integrate both in our disaster trainings here in the state, working with public health nurses and with our students as well, we can't do things the same old, and expect improved access, cost, and quality. And that's why last year, many of you were incredibly supportive. We had just in my Senate office alone, I sponsored 46 bills, and of those 46 bills that passed, I would say 60% of them were healthcare. There were things like the all-payers data set, the behavioral mental health integration, right? Because as we know, behavioral mental health is a huge component. One item during that whole process that we discovered is you're looking at transformation in your practice, whether as a physician or nurse practitioner, a PA, is really looking at that whole person. So as the next administration comes forward, I know myself as a lieutenant governor and Governor John Carney, we want to be there to be kind of like a founding support to those of you who are the real experts. You have a mistake in government when you have policymakers who suddenly think they are the experts, when we really need to turn to those in the room who are the experts. So whether it's the payer side, right, the insurer side, the incentivizers, the individuals, because we know it's about outreach to people in our most vulnerable communities who are driving cost up. And we can pinpoint to the zip code and the census tract who those individuals are, You can, and we can do something. And I'm really encouraged. I always see the glasses half full. I know John Carney does too, and he likes return on investment. If you've ever worked with John, he likes that. He likes to see bang for the buck. And there's no more important activity than what you're doing today. Looking at transformation, thinking out of the box, working due diligently. So I don't want to talk too long. I was supposed to be your 5-minute opening greeter. I recognize I stand between you and lunch soon, or another cup of coffee, or a decaf tea if you're being healthy today. But I just wanted to, again, thank you for what you do. We know that you could be in other places today, but I think collectively we will accomplish a lot. And so whether it's the innovation or whether it's how we train our workforce. And the final thing I will say is my office door is open. I am now on the 3rd floor of Tatnall. I am accessible. I am available. I'm hoping, I kind of have a feeling, I might get to spend a lot of time with y'all. With my health background, I have a feeling the governor is going to kind of swoop me into that area with you to really be there as a team player and collectively really excited with the leadership today and what you're doing. And so for us, Keith Warren is in the back. Keith can wave. I hope you get to know Keith a lot. He is the chief of staff in my office. He'll be working with John's chief of staff, Doug Gramiak. And so today I was basically sent to thank you, to welcome you, and to let you know that John Carney and I stand ready, willing, and able to do anything that we can from a policy perspective to support the work that you're doing, because it is absolutely, in my mind, the most critical, pressing policy issue we have facing the state, because it does augment our economics and involves everything for our entire system. So I want to say thank you for what you're doing. I will stop, and I don't know if anybody had a burning question or a comment or a suggestion. No? Anyone? Thoughts, questions, comments? They have had, their brains are thinking, right? I'm not as exciting as Flo. How was Flo? Was she pretty good? Oh, you didn't have Flo. Who did you have today? Yes. I'll leave it to Cynthia, my colleague, 2 doors down from me at the university. For those who don't know, I teach nursing at UD. I think she mentioned that in the bio, yeah.
So from the payer perspective, I guess they function under the fiscal year mindset for many years. In shifting to a value-based model where there's a long-term benefit, how are they going to make that shift? What could you do from a policy perspective to help support that shift?
Right. And I see others out here in the audience who I know could even answer that probably even better than I, because they live it and breathe it, and particularly from the docs, the medical society side. And you all been working on this for a long time. From a political side, it's funny you mentioned this. I'll give you an example. Sometimes examples help, right? As you're a teacher, examples are good things. Yesterday, state employee benefits, it's a commission that I get to be on. Exact discussion. Are we going to really implement this value-based? Are we going to continue with monetary? Oh, people in the state just sign up for their insurance, and if they don't renew and they don't read the package, we just keep renewing it. We can't. We need to have people begin to appreciate their health care. We can't give them an open-ended Visa card. And we do it in a constructive way, right? And I think from the value-added side, the data that you collect, both from the insurer side, the workforce side, the academic side, database, and I see Susan nodding her head, who knows that it is that data-driven. So I think as you give us the outcomes, because let's face it, folks, I know I go into the highest risk communities in the city of Wilmington in my other my job, 19801, 19802. We can tell you where individuals aren't getting the care. When they're getting the care, it's the expensive ER care. And we can avoid that if we provide clinic hours and doctor's offices and nurse practitioners and PAs, provide those services on a Wednesday night even, because they're not as likely to go. So that value added is a natural, and it comes back to reward us as clinicians, because we're all in it to make people healthier. That's why we went in to become nurses and doctors and PAs and social workers, right? Was to make people healthier. And if we have that the final thing I'll say is mental illness and depression and other factors are huge in our state. We had the Mental Health Behavioral Health Task Force last year. We did stroke legislation. We did all those things that we know save cost. And that's where I think the value added comes in, what it is that we get. So return on investment. is really, really important. And that's the final thing. I don't know how many of you work in some of the communities where we have high turnover with prison reentry, the whole heroin epidemic and issues now. As I look at Dr. Rute, and she works with her colleagues in DSAM, we are seeing 82% of our inmates, 82%, have a mental health substance abuse issue. So we have things that we can do, boots on the ground in the community, value added. And I think, do we have time for one more question? Or okay, go ahead.
One of the challenges that we have in our practice is we have a high Medicaid population, and they, again, back to the value base, they don't really have any buy-in to their health care. I mean, I can't charge them for not showing up. They don't really have any of that structure, and there's no disincentive for them to go to the ER.
Right. Right. And I love that you say that, because that's something I could spend 3 hours on. I won't, but I think with the work that you are doing between, the SIMS and the innovation and the models, the whole issue with Medicaid, I can tell you 4 years ago, when at one point the governor was going to cap the ER visits allowed, I was part of a team that looked at those data. It was 12 million records. We did lots of interviews with some of you in this room. We actually interviewed some of you. And you're absolutely spot on in that individuals who have a hard time sometimes, and again, not all Medicaid patients are, not low cognitive functioning or taking advantage of the system. Many truly are the most vulnerable. Our seniors and individuals who really need it, are the working poor who can't get insurance in between. But what we found was it was just sometimes the hours, the incentives, and I think you're spot on. Like, what incentives do we make? What rewards do we have? Instead of, not having a carrot, maybe we need to think of what is it that we get people to perform for their health care. And what we found was that the high-end users really were not the biggest users, which was the psych meds and pain meds and maternal child issues. It was just in general. People had no reason not go to their regular clinic, because it was easier just to show up when they had an ear infection or their child needed a physical at the same time. And so I think the more we use our data, and that's why I'm so excited to have this opportunity to kind of shift lanes from the Senate. Many of you know me in the Senate capacity, writing legislation. I'm really excited now because I can get down in the nuts and bolts with you, I think, and we can hopefully move the needle a little. I mean, I'm realistic. I know you can't change things overnight, but we can perhaps move the needle and really listen to your suggestions. Really listen. So I want all of you to be writing your thoughts down and what you really see, because sometimes it's the easiest things that are easy to pick up the phone and make a call, or working with Steve Groff in Medicaid, that we can actually make some changes. And as I know, many of you know, and I know the dean and others know, we studied this, and sometimes the data sits on a shelf and we need to move it off the shelf. Great. All right. Keeping you on time.
You are. You're so
Thank you. Thank you.
Thank you very much, Lieutenant Governor. Small token of appreciation for rushing down here and spending just a few minutes with us. But as you know, yes, absolutely. The Lieutenant Governor is well-versed in a lot of the challenges we face, as well as the culture change needed to improve our health care in Delaware and improve the health of all Delawareans. So you should use the access that is available to you. Thank you very much. Another warm welcome. That's why I love it, when they're able to keep us on time. Isn't that wonderful? So we're going to move into our next session, and this is the Team-Based Care and Collective Impact Peer Learning Networking session. Long term to say. We're going to talk about team-based care. This is something we talked about a bit in some of the other sessions, but this is going to be presented with Sarah Lefebvre, who is the Director of Community Health Initiatives at University of Delaware. But more importantly, she has been integral in the development of the University of Delaware learning and relearning curriculum for the workforce. And she will have her panel come up and be ready to talk about that. Is that okay?